Okay, welcome everyone to the continuation of Back to Basics. Although today's topic is a little new, but we're continuing the series theme. So today's webinar is our first for our new fiscal year, and it's on Health Disparities Impact Statement. So we'll get started. Our good old background. All right, so Dr. Shaya, do you have anything to welcome?
Well, yes, absolutely. I would love to welcome you again, thanking our team members, Dr. Taylor, Nicole, Vanessa, Rana, and Paris, our valiant core team members. I want to thank everyone for attending, and mostly also OPHI, Helene and Brooke, and Latiqua for making this possible. So I also want to say a word that we are here as your TA providers, of course, working with OPHI. And I do want to reiterate that any needs that you have, please contact us for TA, for process or evaluation. We are really staffed to do that. And we always try to be responsive very quickly and help you in all your needs. With respect to the disparities statement that we have the topic on today, I also want to say that after 20 years of working in the field, we are still struggling with how to bridge disparities. So please think about it as more than just checking the box today, or more than just writing a statement. We are all here to impact disparities. So the statement is only the beginning, and it's more than just counting and seeing what the differences are. We know there are differences, but we want to take this as a platform and perhaps a sounding board so that we can see how best to continue to impact disparities. And with this, I will give it back to the team, back to you, Nicole, and everyone, OPHI. And again, thank you everyone for participating today.
Thanks. So just our quarterly reminder, or I guess however often we speak of every time, just if you haven't subscribed to the BERT newsletter, the link is here. For everyone to sign up, to be able to get sign up and receive information from the BERT listserv. All right. So now we can start and turn it over to OPHI for any welcome or updates from your end.
Good morning, everybody. We are excited to have this first webinar of the new fiscal year, and thank you everybody for participating. We don't really have any administrative updates at this time.
Okay, so before, just wanted to get started about some of the new FY24 sort of conditions of award that we'll be going over today. So there were two main updates to your FY24 plans that we want to review in today's webinar. First is the appendix of required activities and performance measures. I'm going to discuss this a little bit more on the next slide. And then the main goal of today's webinar is the Health Disparities Impact Statement. We introduced this to you during the last webinar that we held in May, but today's webinar will provide some more background and guidance on submitting your impact statement for your plans. So before we dive deeper into health disparities and the impact statement, I'm going to review the appendix of key activities and performance measures. So I'm going to quickly share my screen, Paris. Can everyone see this all right? Okay. moving things around on my screen. All right. So we created this appendix to sort of help highlight for everyone some key activities that go with some of our main strategies that everyone has implemented. And we kind of labeled it performance measures. They're really key evaluation indicators, and they're a combination of process and outcome measures that you should be collecting that will really show implementation and impact of your strategies. So we have academic detailing, just some of the key activities there for those that are participating and are part of that, implementing that strategy. Simple things of participation in calls, completion of their forms and webinars, and then just following the standard protocol. And then you can see the specific key data points that we want you to collect. Naloxone distribution, the key things is really just collecting all the evaluation data. It's pretty standard implementation. So some of those things, examples are, number of kits distributed, trainings, surveys that you might have collected, and the people reached and by type. A lot of people are doing community-based process. And so just as a reminder for that strategy, you're implementing the SPIF process as a strategy. So some of the key components there are maybe updating a needs assessment, building capacity and partnerships, leveraging your resources. And so doing that through collection of local substance use data on consumption, consequences, risk, and protective factors, completion of a community capacity assessment. So we have the community readiness assessment, as well as community mapping of prevention partners and prevention programming, as well as community mobilizing activities. So dissemination of prevention activities, raising awareness of prevention, as well as risk and protective factors, and establishing a coalition work group or enhancing a coalition. So really mobilizing around what is prevention and how do we implement strategies and build support in the community. And so with that, just things to track obviously are like more benchmarks of the surveys you've collected, the components of the activities, partners you've been able to identify, collaborations, new strategies, and just overall trying to keep track of increases in knowledge of substance use prevention problems and initiatives in your community. So everyone, and then just another quick one is prevention education. A lot of people are doing all different types of prevention education programs. So the big components are really following the fidelity of that curriculum that you are implementing. So implementing the session, all the sessions, the pre and post tests, following the modules, and then collection of all the evaluation data. So key things there, right, for prevention education are dose, so number of sessions, the reach, those counts, so number of participants as well as by demographics. It's helpful to know surveys that you've collected to get the total counts, and then the impact of the program. So whatever the goals are, that percent of participants with a behavior change that you're intended to focus on. So those are.
I'm sorry, excuse me. Could you scroll down some, please?
Sure.
I apologize.
Yeah. All the way more.
I don't know if the screen is frozen. I see community-based process, SPF, and I know you started going into the number of surveys collected, but I can't see beyond that.
Oh yeah, it did. I can see that something went weird on my screen. Well, we will be sending this out, and everyone should have received the form. So, and the other thing that I'll just make note that I'm gonna stop sharing actually and just pull it back to Paris to share the slides. But I'll answer your question, Mary. So the one thing is that all of as you're implementing your strategies this fiscal year, you just want to make sure that you're kind of looking to see if you're touching those key activities for the strategy. And during the FY24 calls that we've been having with individual jurisdictions to sort of review how things went for your first year of your 2-year plan and what adjustments might need to be made, we'll go over these more in depth with you to see where things don't align or where you might need some assistance to be able to collect that data or what activities you might need help with. And for the key performance measure of naloxone, the evaluation data is just being able to collect evaluation data is just a key activity, not necessarily a performance measure. What you're collecting would be the data indicators for the reach and dose. So like how much naloxone kits, how many people have been reached, breaking it down where and how and to who and all of that. And if you collect any and then how are you measuring any sort of impact? So all of your other evaluation indicators, just that you, from your evaluation plan that you're following, and those are key activities. The rest of naloxone, I think people have a little different approaches. So we didn't go into too much detail of what is required for that. Only if you are doing naloxone as for your strategy. So these listed like examples of strategies that different jurisdictions, a lot of jurisdictions are implementing. So we just highlighted the ones that most people were implementing. So if you're not doing naloxone as one of your as part of your plan, then you wouldn't have to report it. This is just for that. For Rondalyn for academic detail, and we'll go over this more in depth, but yes, those, and a lot of the detailing performance examples of data indicators are actually collected by completing these detail and session report forms, and it's not additional, it's really not additional data that you have to collect. It's just you would be able to report that and gather it. So we'll answer more individually, but just wanted to remind everyone that this was shared, and if you have any questions, if you we'll be able to go over that with everyone on our individual calls. So now we're going to move on to the main topic of today's discussion. Here's mute the next slide.
I'm not sure what's going on with Zoom because on my screen, it 100% says I have gone on to the next slide, but on yours, it has not. So give me a second. Let me unshare and then share again.
Okay.
I'm going to chalk it up to Zoom having some technical issues today because it has really been acting up. All right.
All right, there we go. Sweet. So 3 main points for the goal for the rest of today's presentation is to understand what a health disparity impact statement is, to understand how to analyze that. So the research, the back methods used to create a health disparity impact statement, and then the steps to develop your own health disparity impact statement. So what are health disparities? So Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. So further definition of a health disparity is a health difference that adversely affects disadvantaged populations based on one or more of the following health outcomes: higher incidence and/or prevalence and earlier onset of disease, higher prevalence of risk factors, unhealthy behaviors, or clinical measures in the causal pathway of a disease outcome, higher rates of condition-specific symptoms, reduced global daily functioning, or self-reported health-related quality of life using standard measures, premature and/or excessive mortality from diseases where population rates differ, and a greater global burden of disease using a standardized metric. So what is a disparate population? Disparate population is a subset of the population that is at highest risk for health disparities. Examples include racial and ethnic minority groups, people with lower socioeconomic status, underserved rural communities, sexual and gender minority groups. So now Dr. Taylor is going to go over how to identify disparate populations.
So I don't know if that's the real Latika or somewhere else, but there seems to be some feedback and stuff going on. So we apologize for any technical issues. It seems that Zoom is having some issues, but hopefully we will share this recording as well as the slides for today and resources that hopefully if you miss anything in the presentation, you will be able to piece it together. And then we're always here to assist you through it. So as Nicole said, let's talk about how to identify that disparate population. So first, you really have to understand the role of social determinants of health, which Nicole, touched on a little bit when we're talking about certain categories. And this is what we're going to talk about today and how to identify that. This can really help you if you know what the social determinants of health are and have an understanding of that and how it affects the community. It'll help you identify that disparity or problem, the population of focus, and inform the development of accurate measures to study and improve those outcomes. You can identify them through these categories that you see on the slide. So education access quality, healthcare access quality, neighborhood and building environment, social and community context, as well as economic stability. And we'll take a little bit of time to discuss each one of these. Next slide, Paris. So the first one was education access and quality, which would look at your access to high quality educational opportunities. So examples of this would be, you see how this would break down on the slide, but an example would be maybe a child from a low income family or a child who routinely experiences discrimination or bullying may not finish high school. So these individuals are less likely to have a safe or high paying job and may face challenges that stem from having low income, which can negatively impact their physical and mental health. Components of it would be things like a self-reported lack of school engagement in adolescence, such as skipping school or being suspended, is related to the development of drug use disorder later in life. So if you were looking for specific data points that you might pull that are directly related to these factors, it would be things like in your county, the number of households without any type of computer access, or maybe lowest percentage of students that have completed high school, or lowest percentage of students enrolled in public school from kindergarten through K through 12. Next slide. The second one is the healthcare access and quality. And that would be things that have to do with high quality healthcare services that are offered to residents living in a given area. So For example, people without insurance living in an urban community may have difficulty finding affordable services such as disease screenings and yearly checkups. Those with insurance living within that same community may also face difficulties such as finding healthcare providers in a crowded area. And since substance use is traditionally viewed as a social or criminal problem, people needing care for substance use may have limited range of treatment options that may not even be covered by their insurance. So some of your data points that would go along with this that you might look at would be something like counties with less than 20 total primary care physicians. Next slide. The third one is neighborhood and built environment, and this would be places where people live, work, learn, and play. So this is inclusive of, stable housing, clean water, safe playgrounds, the rate of violence and exposure of crime in your area. So an example of what you should be thinking about with this would be children who grow up in areas without access to playgrounds or community activity centers will have difficulty finding safe recreational activities. They may also be exposed to crime and violence from a younger age. So an example or a component of this would be like if you were focused maybe on Baltimore, it's found that opioid use among youth was the result of several structural inequities. And for children with and young adults who reside in this urban setting, it is critical to develop appropriate interventions within their community. So some data points for this would be things like again, looking at enrollment in schools, rate of crime in that area. Those would be the kind of data points you'd be looking for. Okay, next slide. Social and community context is our next one. This includes discrimination, rates of incarceration, and social support within the community and the civic engagement. So an example of what you should be thinking about when you're looking for this data and including it would be if a child who suffers from severe bullying at school has a weak support system from their family and their community, they will likely face more negative outcomes from bullying. This is compared to a child with proactive parents and a supportive school system. The community context, it really can impact how safe members of the community feel and how likely they are to ask for help and trust community members such as law enforcement. So some of your data points that would go with this that you would connect would be things like counties with the highest social vulnerability, or the most diverse counties and what that actually looks like. Okay. And then last but not least, we have to look at economic stability, the ability to afford food, education, healthcare, and housing. So examples of that would be for an individual with stable employment at a company that provides health insurance. Is it possible to take off work to see a doctor if they experience illness? However, an individual who works as a contractor, right, employee without benefits, they may be able to take a day off, but they would lose pay, as well as pay to see that doctor out of pocket. So these components are really important when we're thinking about looking at housing insecurity, defining costs, poor housing quality, poverty, food insecurity, all those things would come into play with this one. And a couple of data points would be things like public schools, looking at the highest percentage of school-age children in poverty, counties, unemployment rates, right, and their rates of food insecurity. So we know we've got the data, we're looking at the categories. And so how do we actually identify those populations? What do we do? What are our steps? Identifying that disparate population involves recognizing groups that experience unequal health outcomes or access to healthcare services compared to other segments of the population. This is what we're going to look at in the next 2 slides will be things that you can do or the steps that you should be taking to identify those disparate populations. The first thing is to analyze the health data. So you examine the health data, including mortality rates, disease prevalence, and healthcare utilization rates to identify groups with disproportionate poor health outcomes. You want to look for patterns of disparities based on factors such as race, ethnicity, socioeconomic status, gender, age, and geographic location. Evaluate your access or their access to healthcare services, including preventive care, screenings, and treatment. Identify groups that have unlimited access due to barriers like lack of insurance, transportation, or even healthcare facilities. So for example, you would use a service such as Policy Map, the state census data, or Maryland Data Center census data to really understand the characteristics of individuals in the area that you are trying to study and create resources for. The second thing you're going to do is to compare demographic characteristics. So in order to do that of different population groups, you want to look to identify those disparities. Look for groups that consistently face higher rates of certain health conditions or lower access to healthcare services. Historical and structural factors. You're going to examine these factors that contribute to health disparities, discrimination, systematic racism, and policies that have disproportionately affected certain groups can really lead to those disparities. The fourth one is health behavior patterns. You want to analyze this, and this would include things such as smoking, substance use, physical activity, nutrition. You're going to identify groups that engage in risky behaviors or lack access to resources that promote healthy behaviors. The fifth one, the final one on this slide, is the mental health and well-being. This would include mental health conditions, access to mental health services, and stigma. Stigma is a big one that we know can apply in many areas. Identify groups that face mental health disparities and identify individuals that may be at a higher risk for those mental health conditions. Because we know that sometimes with combined conditions, right, you can have a higher risk for certain other mental health conditions. Next slide. The sixth category, and I know we don't have them labeled here, but again, we will share these slides with you. The sixth one is the geographic disparities. You want to recognize these disparities based on a geographic location. So rural and urban populations may face different health challenges due to access to healthcare facilities and resources. Using housing data from the above census data, understanding how income and geographic disparities can impact access, to care and treatment. The next one, which is number 7, is vulnerable populations, paying attention to populations that are particularly vulnerable, such as pregnant women, children, older adults, individuals with disabilities, and the LGBTQ plus individuals. The 8th category is healthcare utilization patterns. That's investigating how people are utilizing healthcare, right? So including emergency room visits, hospitalizations, identifying those that are, at higher rates of avoiding, right, that healthcare utilization. The 9th one is community input and stakeholder engagement. engaging the community members and stakeholders to gather insight on disparities that they perceive. And then last but not least is number 10, which is literature review. So you want to conduct a literature review to identify existing research and studies that highlight health disparities among different population groups. And if you're not sure how to do a literature review, that's another thing that you can reach out for some assistance through TA. And so we're going to launch just a quick poll. I know we've thrown a lot of information at you. So Nicole's going to launch a poll for you with a few questions. Hopefully Zoom cooperates with us, right? 2 questions. So I said a few, it's only 2. If you can quickly answer on the poll. Hopefully everybody can see it. I see people participating. So as you are answering them, I'll just read them real quick. Have you looked at the data to identify disparate populations? What data sources have you used? And I guess, Nicole, in the thing, they're able to actually write in their answer. So we'll see it in the...
Yeah, I did it as a free response just to make it easier than trying to come up with tons of options.
Okay, sounds good. So give everybody another minute. Is anyone having problems accessing the poll? That number is slowly going up. I only see 17 responses so far. There we go. Thanks, Todd. Come on, guys, answer those questions. Couple more. Should at least get 50% participation with 66 people on the call. Maybe 10 staff members. Couple more. All right, can I get 3 more people to participate? Let's go. Answer the poll, and then we're going to move forward. I got 1. Oh, okay, so someone couldn't see if their poll answer was submitted. They just see poll and discussion on the screen. It should have been submitted. If you hit submit, it should have. And someone is messaging me as Latika Holly, but I think it may be somebody else. Did you want to type in who you are or change your name?
Looks like we've kind of lulled. I'll end it in 5 seconds. Give us 4 minutes.
Yeah, that's good.
All right.
Oh, Doreen. Okay, thanks.
Hi, Dr. Taylor. It wasn't me.
Okay.
All right, so I can share the results. And then
Okay.
the details for the second slide, I'll just, or the second answer, I can read them. So,
I'm sorry, Nicole, you're breaking up. I don't know if it's because both of us. What did you say?
can you, am I not clear? Can you hear me?
No.
Nicole, I can hear you. I hear whatever feedback folks were talking about is happening when the both of you are on. So I don't know if you need to mute and while each other is speaking. But anyway, Nicole just what did you say, Nicole? You said something about the poll is on the screen, and then
Yeah,
she'll read
I
off
have the details for the question 2. I have it to read what people entered.
She will read the answers to question 2.
Okay.
Did you hear that, Dr. Taylor? You might be on mute, but it's okay.
Yeah. All I hear is double feedback from both of you.
Oh Lord. So then that means it's Nicole's thing, and I'm going to shut off.
All right. Well, is this good for you, Michelle? All right. So as we can see, about of those that answered, 65% said that you have looked at data already to try and identify disparate populations. 35% haven't yet. So this will be a fun new task for you to do in this next month. And some examples of data that people have looked at, and maybe we can have people raise their hand to that entered that what they did to kind of share how they used it and who they identified. But data provided by state and county organizations, MISA, and the Anne Arundel Health Disparity Survey. So that's a good one. Income, demographic data, Garrett County Health Inequities Analysis, their health department epidemiologists, state data, healthcare access and quality, U.S. Census, state data, overdose data from the Sheriff's Report and the VSA, another overdose data, Anne Arundel County Poverty and Misplenty Report, the YRBS Report Card of Community Indicators, Maryland Vital Statistics, community surveys and with demographics, local hospital data, and YRBS. So for anyone that shared, and I can definitely call out some people that gave their counties in their responses, what you guys have, any particular populations that you've been able to identify from some of your data that you have used, and how you sort of are using this, what disparate populations you've identified and how you're implementing strategies with those populations.
This is Hillary from Frederick County. I'm the epidemiologist in behavioral health. And we've been looking at a couple things. We get the Urbis report cut by LGB. Unfortunately, the other letters are left off, but we can at least look at those. We produce a report for the Frederick Center, which is our local pride center. And I'm also using the vital statistics to look at rates of cesarean sections to see if there's any health disparities there.
Great, thank you. Anybody else like to share?
I can share, Nicole. This is Amy from Carroll County. Can you guys hear me? I can
Yeah.
see you nodding, so I'm going to say yes. Okay. So the Center for the MDH Center for Tobacco Prevention and Control did like an analysis of the YRBS and pulled out data with respect to ACEs and gender identity that was incredibly helpful. In terms of what percentage of those populations were saying yes to specific questions. So that report's been really useful to help us direct some of our programming.
Great, thank you. Anyone else like to share? Love to hear what everyone's finding and how they're using the data.
All right, well, from Howard County, we've been looking at a great deal of different types of data. and we're calling it data for risk. So we're looking at YRBS, we're looking at poverty, we're looking at WIC, we're looking at high school dropouts, we're looking at VSA, we're looking at OFR. We're using, like, there's probably 18 or 19 measures we're looking at for trends as we create a heat map of where the highest areas of risk are in our county.
Great, thank you. All right, if everyone else feels like they want to share in the chat, go right ahead. If not, I'm gonna turn it over to Paris, I believe.
Thank you, Nicole. So how to implement strategies to target desperate populations. And this is evidence-based structural interventions. So we're going to make sure you're inclusive. That's the first step. So authentic engagement. Successful structural interventions demonstrate that in populations affected by disparities, community stakeholders can be active, equal partners in designing and evaluating structures, interventions, and I'm sorry, let me restart because I'm sounding choppy. Authentic engagement. Successful structural interventions demonstrate that in populations affected by disparate communities, stakeholders can be active equal partners in designing and evaluating structural interventions and in the advocacy and policy translation processes needed to sustain the scale of these efforts. The second step is disease agnostic interventions. Structural interventions that successfully address health disparities and improve minority health and disease agnostics in their approach. This also is enabling them to tackle common risk factors that lead to multiple health disparities, thereby altering the context, the yield, the social inequalities. Among these are policies and practices that focus on changing the mechanisms and trajectory of risk factors that lead to health disparities. So a good example are things like Parent Corps. The third is timing and location. And this is identifying geographic risks associated with residential neighborhood factors. And these can inform local area capacity buildings and propel cross-sectional interventions that directly or indirectly reduce health disparities and improve health outcomes. And the last is take account of unintended consequences. So these are structural interventions. Structural interventions must be developed and evaluated with sensitivity and appropriateness to existing local sociocultural structures. And these should be planned and tailored in collaboration with communities directly impacted by the intervention. These should integrate cultural, historical, and psychological factors that influence targeted behaviors. Here are some other general principles that you should follow. So the first is collecting data and identifying disparities. So you want to gather the data on the health outcomes, their access to healthcare, and social determinants of health within different population groups. Then you're going to identify where disparities exist and understand the root causes of the contributing factors in these differences. The second is to develop and understand culturally competent care. So develop healthcare programs and services that are culturally sensitive and relative to the needs of the specific population. This includes understanding cultural beliefs, languages, and traditions to provide effective care and communication. The third, equitable access to care. So we want to ensure that all individuals, regardless of their background, have equal access to quality healthcare services. This can involve identifying transportation options, expanding clinic hours, or even using telehealth to reach our underserved communities. Health literacy and education. So this is where we provide educational resources that are easily understandable and culturally appropriate. So we access health literacy and communication with individuals within disparate populations at their health literacy level. And this empowers individuals to make informed decisions about their health. So this includes things like using plain language or using the vernacular of that community or that community so that they can make the best decisions for their health. Tailored interventions. So we develop interventions that address the unique health challenges faced by different populations or groups. So tailor interventions, we tailor prevention, treatments, and support services to meet the specific needs of each community. Community engagement. So we're going to engage with community leaders, organizations, and members to create solutions that resonate with the local population. We're going to collaborate with community partners to implement effective interventions. Workforce diversity. So we have to increase diversity within the healthcare workforce system to ensure that patients who have access to care are comfortable and they understand the care that they're receiving. And this allows them and their providers to understand their background and their experiences. Policy and advocacy. Advocate for policy changes that promote health equity. Support legislation and initiatives aimed at reducing disparities and improving healthcare access for all populations. Data monitoring and evaluation. So continuously monitor and evaluate the impact of your strategies. Regularly assess whether disparities are being reduced or adjust your approach based on the outcomes that you see. Address social determinants. So that means recognizing that health disparities are often rooted in social determinants, such as housing, education, employment, and income. Collaborate with your local social services and community organizations to address some of these factors. Reduce stigma and discrimination. Work to reduce stigma and discrimination associated with certain conditions, as this can deter individuals from seeking care. Promote understanding and compassion with your healthcare systems as well. Partnerships and collaborations. You want to collaborate with your governmental agencies, nonprofit organizations, community groups, academic institutions, and you all want to work together to pool your resources together. You all have a different set of expertise, and all of these expertise can be used together in addressing health disparities. Long-term commitment. Addressing health disparities is an ongoing process that requires long-term commitment. So this is not something that you're going to be able to address within 1 quarter, 1 week. This is something that has to keep going and be a continuous effort. Sustainable change takes time, and persistence is key to achieving lasting efforts and improvements. Transparent communication. So we have to maintain transparent and open communication with the community you're serving. Keep them informed about your initiatives, the progress, and the opportunities for engagement. And the last is flexibility and adaptability. Recognize that strategies might need to be changed depending on the circumstances. So sometimes there's new research, there's an evolving community need, or your population may be slightly changing. So tailor your efforts to the specific needs and context of your population you're targeting to create meaningful and sustainable change. So here's the good part. So here are some examples of health disparities impact statements. These impact statements show various aspects of health disparities related to substance use disorders, encompassing socioeconomic factors, race, LGBT plus identities, age, geographic location, and maternal health. So these slides will be provided to you, but I'm going to read a couple of them that I thought kind of stuck out. And to me, these are kind of like, in my terms, mission statements. So these are mission statements of what you're going to do. So the first one I loved was youth substance use disparities. Health disparities among adolescents are evident in substance use patterns, with some groups experiencing higher rates of initiation and addiction. Early intervention, education, and community engagement are essential to reduce these disparities and prevent long-term negative consequences of substance use among youth. The other is LGBTQ plus disparities in substance use. LGBTQ plus individuals confront unique substance use health disparities resulting from stigma, discrimination, and lack of tailored support. Substance use prevention and treatment programs must be inclusive and sensitive to the specific challenges faced by LGBTQ plus individuals to mitigate the disproportionate impact of substance use disorders within this community. So again, we'll be sure to provide these to you. That way you have tangible examples that you can use, but these are some examples for different populations. I'm going to pass it back to Nicole. I believe she'll be sharing her screen with you to share some additional resources for you.
Back again. So we went over, Michelle went over some examples of data resources, and we just wanted to share some links of some other reports that exist. One that we've created, a social determinants of health report that our team put together, that has examples, a lot of the examples that Dr. Taylor went over, as well as specific data for those areas. So we will send that report out. And the other is, I'm going to just drop this link in the chat. This was sent out from the PGCC network, and it was just about other ways to think about when addressing adolescent opioid misuse and overdose, which all of us are focusing on. And it just kind of breaks down some of the other factors, one of which they highlight is violence, and how to utilize some of that data when designing additional types of prevention interventions, of just identifying certain populations to target with your interventions. So now the fun part. What are you guys going to do next? OPHI is asking everyone to, and I'm going to let Brooke come in at the end, but develop a health disparities impact statement. So we've developed a guidance document, so I'll bring that up once we go over this slide. So what we have is, all that we're asking each jurisdiction to do is develop a statement on the targeted disparate population. Use the examples as a template. So some of those examples that Paris went over are just the health impact statements that we think are pretty straightforward and simple for you guys to develop, and to sort of say who you're targeting and how you're going to address this population. And then for you to provide the data to support this targeted population that you've identified. So to provide the actual data to support how or why you identified or selected this disparate population to target, as well as any data indicators to track. So when you are within your strategies, for your additional ways that you're going to try and identify this population to target, what other indicators are you going to be tracking to make sure that that population is being impacted. So these submissions are going to be due at the end of the month, so on September 29th. And let me pull up. We have a full example for you, but we have to update this, so don't worry about that. But when this gets sent out to you, and okay, I can see it in the preview. So this just highlights some of the key points that we shared also in the presentation. So the definition of health disparities, some examples of health disparities and disparate populations, the steps of data sources to identify those populations. So the different ways that you can identify which population you would target, and the examples of impact statements that we went over. So this will be completed but this is an example of the form for jurisdiction Candyland. When you receive it, this all will be completed for you. But essentially all you'll have to do is identify which disparate population you're going to target, your health disparity impact statement, and then the data that you have that you've used to identify that population, and as well as just any data that you're going to use to measure progress and outcomes to show how you were able to improve the disparities and close that gap within your identified population of focus. So I know a lot of you have already are doing strategies, and some of you might have already have identified maybe a disparate population that your strategies are targeting, or if you have sort of a general, if you've been doing more universal within one of your sessions, is there a way to recruit more of a disparate population? I know a few jurisdictions already do some targeted interventions, but I know that's the goal, is to try and think, I know we've been talking about this for the last few years, to really think about how can we look at the data and really target some of these populations that are more at risk to help trying to close the disparities. So that's the document. And if we have any, now it's just like really any questions for this, if anyone, for the next steps, as well as anything that we've shared with you today.
There are definitely questions in the chat, Nicole, and I don't know, this might be a time that Brooke wants to chime in.
I believe it's just, I'll let Brooke chime in, but it should be just overall, not per strategy, but just like thinking about within, to identify a disparate population, then maybe within one of your, how you can address that within one of your already selected strategies. So for example, if you're doing a prevention education program, it might be some of like more targeted recruiting for one of your, for one of the sessions, you know, that you offer. I know some people do some targeted outreach, and if people want to share some jurisdictions that already have started to do that, or how they had, from some of their identified more at-risk populations, how they already are working with those groups with implementation.
Hi, Nicole, it's Caitlin. I was gonna keep typing in the chat, and I was like, that's just better to pop on. So you're saying like the population doesn't necessarily have to fit all of our strategies. We're just selecting one population that our strategies are impacting and focus on that.
You would be selecting based on the data, like a strategy, a population, right? That is a disparate population, right? So it might be identified that based on the data of what you guys have looked at, and as on the other maybe social determinants of health factors that, you know, is more at risk maybe for substance use or other negative outcomes. And a member population doesn't be demographic, could be geographic as well, right? It could, you know, there's community context, you know, so there's all those different levels that a population can be defined as. So maybe it's that you would do something more in one area of Anne Arundel County because of what the data is telling you.
Okay, so it doesn't necessarily, that population we select doesn't necessarily have to be for all of our strategies.
Correct. And I will let Brooke or Helene, if she's on the call, to jump in, but that's how I kind of, yeah, it's just for this time, it's just like identifying a population, how are you going to reach them? Yeah, it wouldn't have to be for all your strategies for sure, because that wouldn't make sense.
Okay, thank you.
So Adrian, I think your question was sort of similar, right, about the overall prevention plan. So I think it would be, it doesn't have to be, it should fit within like within some of your strategies right now. If you have to make some tweaks, I think like in terms of like maybe a branch within a strategy, but everything always is like identifying how you're going to reach different populations, right? And we're always reassessing that. And you're going to say like a couple, like within that impact statement, sort of like what you're identifying, how you're going to sort of target it. So you can explain it in that way, like within maybe a strategy. Do we need to report how we have impacted this population at the end of the year, or is this statement just for informational purposes? So the statement is sort of like your goal, like Paris said, almost like your mission statement, right? Of like what you're hoping to accomplish. And then the data to support is how you identified it. And then we're asking you to identify ways that you'll measure progress. So that would be something that you'd want to be collecting, like always, to kind of have some sort of looking at what are the data indicators that you might be able to pull, probably similar to what you would use to have identified that population, to just be able to see what progress you've made, not to say that you've completely, changed anything, but we just want to measure progress. Progress is always helpful. Any other questions on the big picture? I know, Louise, you were kind of joking about the term of disparate population. It's hard to say, and it is sometimes sounds like desperate. We can call it targeted population if we want to make it sound, but the formal term of the population that is the health disparity.
That is so new for me.
Yeah.
But I think it was an important, I'm glad that she put that out there, because it's an important point to make, the fact that there is a difference between disparate and desperate. And so I thought that was great, Lucy, that you showed some vulnerability there, just to say, wait a minute, those terms are very different. And this is making a little bit more sense to me about the focus on disparate populations. So, but I think it's too also important to mention, and maybe Joseph, I don't know if he can speak up to talk about his example that he put in the chat.
Yeah.
Because there you are really targeting, and obviously he has a very targeted population that he's working with at a university, but I think he included a lot of great factors in there that sort of summed all this up as to what they're doing. So Joseph, I don't know if you want to talk about it really quickly, or if you didn't read it in the chat, take a minute to read it from Joseph.
Yeah. Hi, can you hear me? It's lagging a little bit on my end, having some issues with Zoom today. But yeah, we we collect data through the Maryland Collaborative, and we usually are looking at different counties from where students are from, their sexual identity and genders. Every time that we have tables, we try to target certain groups of students, and we partner a lot. BSI is the Black Student Institution. We partner with a lot of different Greek organizations that are different religious organizations as well. A lot of our trainings, we go to Catholic Campus Ministries or the ministry on campus, and we try to partner with those types of partners to try to get involved, just to target students better, depending on what groups they're in. And some students like help to volunteer, so some of the Greek organizations are volunteer focused. So really just seeing what issues the campus is in need of, and how we can use the organizations and the people that are around us to help better their peers.
Thank you. And Mary, thanks for pointing out that sometimes targeted can be somewhat of a not great word. So we'll try and most at risk. They like to use the term most at risk report outcomes. So yeah, it's always careful to terminology. And Jackie, are we submitted an impact statement for our county or one for, so SABG and OPP are really the one application. So, but I know you guys are kind of unique, so maybe have an opioid chat. Brooke, I don't know, do you want to have I think it should be just overall, but I'm not sure how that would work for your team. Any other questions for what's required, or just in how to identify the data, what data to use, our access? If you hadn't looked at data yet to identify a disparate population, definitely reach out. So if you need we provided the examples, but how to access some of that data, we'll share the social determinants of health report that we created. It gives we listed a bunch of data. That uses the community health rankings report, that whole website. I don't know if you guys have utilized that before, but that breaks down, it basically pulls all the social determinants of health data. And a lot of it comes from census, but it's already kind of pulled for you into the different categories. So it's just within your county, but if you can look at that, I guess it's at the county overall, but if you're able to ever look at sort of mapping things out, I don't know how with some of the other data, then you can kind of try and map stuff if that helps for reach or access. Brooke, I know you said you bring you guys on to.
Good morning. It's still morning, correct? Yes, sorry. Good morning, everybody. Of course, we thank the BERT team, as always, for an insightful presentation, and we know that you all got a lot out of it and that we'll be able to successfully move forward with these new requirements and asks. I am coming to you because I have unfortunate news. No, I am not leaving. You all still have me. That is not what I'm here to tell you. But the unfortunate news is that Alicia Owensford from Baltimore City, out of Behavioral Health Systems, Baltimore, goodness, pardon, unfortunately passed away a couple days ago. So BHSB is certainly, in Baltimore City, is certainly feeling that loss. And so they'll be going through a lot of things, so keep them in your thoughts and send kind sentiments towards BHSB. But just wanted to share that information. I know there is, for anyone who might have known her and engaged with her, we will share that information because we are able to about her funeral that's coming up. Oh, is that Adrian? I don't know if you wanted to share anything. I see you in the chat.
No, yes, that is me. Thank you. Just thank you for your grace and condolences, Brooke. And for those who are on the call, we are deeply saddened by our loss and are working towards healing.
Absolutely. So I don't mean to end on a sad note, but we're a community. We're all in this effort together, trying to help Marylanders, and so just wanted to share that with you all. I don't know if there's anything else. I don't have anything else, at least.
I will make sure to put this. Sorry, that's a totally different change of topic.
No, you keep going. Nothing to apologize for.
But sorry, I'm really sorry to hear that. The now change of topic that came through on a private message, but I'll make sure when we send out the guidance that your submission will go to OPHI for the health disparity impact statement, but you can go ahead and CC BERT. But if you need any assistance completing that, definitely reach out to your TA leads for this.
I think that's it. So, Helene, when is the health disparity statement due?
It would be due September the 29th.
Okay. I know BERT is generally is always open to you all, sharing the statement with them if you need help, drafting it and all of that. So we thank BERT for being available. and supporting in that way.
All
And
right.
with that, that's it.
Yeah, I think that's it. Yeah, we should be able to send that out to you, Caitlin, today. I know we have everything all ready to go. Yeah, this call, yeah, since we were quick topic, you guys were blocked for 2 hours, but you get to end early, so that's great. You have blocked time in your calendar that you can utilize. So that's it. If you have any questions, definitely reach out. And our condolences from the BERT team to BHSB, and we will send all this out to you guys later today.